Hello, ma'am. Good morning.
Good morning, sir. Jai Hind. Welcome to
Hello,
Samarpan.
ma'am.
How are you?
I'm good, ma'am.
Thank you so much for accepting our invitation and joining as a part of a series of webinar. Thank you so much, Rahul sir.
Okay,
We
ma'am.
already finished, I think, 50% of the disorder, digestive disorder,
Okay.
and rest you are going to take today. So our students are in the class. There is a bunch, means all the classes are seated. Another college also they make their student to sit in the audio or classrooms, and they have joined. We'll take 1 or 2 minutes more and then we'll start, sir. Because it
Okay.
is
Okay,
it
ma'am.
is very long, 2 hours is rush. I hope you are comfortable for 1 or 2 minute rest, sir.
Sure, ma'am. Sure.
Thank you so much. Uh, Team, you can start within 1 minute. Let them join, no issue. तो शांग से स्टार्ट कर लीजिए.
Yes, ma'am. Jai Hind and welcome everyone to day 7 of this national webinar series. With great honor, I shall now introduce our keynote speaker for the day, Mr. Rahul Sharma sir. Sir is currently serving as the principal cum assistant professor at Ruma Institute of Medical Sciences, Pratapgarh, Uttar Pradesh. Sir, specialization has been pursued in medical surgical nursing, focusing on cardiovascular thoracic nursing. Sir has academic qualification including Master of Science in Nursing from RML, Bachelor of Science in Nursing from Tirthankar Mahavir University, Moradabad. Sir has held key leadership roles as Chairperson, Nursing Services Section, TNI UP State Branch, State Spokesperson, Nursing Teachers Association of India, Co-Chairperson, Southeast Asia Regional Hub, Nursing Now Challenge UK. Over 5 years of academic and clinical experience have been accumulated by Sir, including service as an MSc Nursing tutor at Indira Gandhi College of Nursing, Amethi. His research work include contribution as a research project nurse in collaboration with CDC ICMR, focusing on infection control and antimicrobial resistance. He authored a thesis on complication of cirrhosis and community attitude towards mental illness. National recognition has been gained through organization and moderation of nursing workshop, virtual seminars by Sir. Sir certified in simulation-based education, SET University, advanced nursing leadership, CPR, AED, BLS, and digital health. Sir holds active membership with professional bodies, including TNI, NTI, Nursing Scholar Society, ACNAP, EMA, and Nursing Now Challenge. He is fluent in English, Hindi, Punjabi, and Bhojpuri. Today, Sir will be speaking on the topic of digestive disorders. On behalf of organizing team and all the participants here today, I thank you, Mr. Rahul Sharma, sir, for taking this time to be with. We look forward to an engaging and enlightening session. Without further ado, me hand over to you, sir. This session, Rahul, sir. Thank you. Virtual stage is yours, sir.
Thank you, sir. Is I'm audible?
Yes, sir. You are audible.
Okay. So, greetings of the day and good afternoon, respected faculty, nursing professionals, and dear students. Thank you, Samarpan Institute, especially Dr. Deepti ma'am, for this opportunity to contribute to such a critical dialogue. Uh, Sir already given introduction about me. I'm working as a principal right now in the School of Nursing, Roma Institute of Medical Science, Pratapgarh, and I have more than 7 year of experience in the field of nursing. During these years, I worked as a scrub nurse, occupational health nurse, ICMR research project nurse, MSc tutor, and currently working as a principal in School of Nursing, Pratapgarh. In additional, I just want to share I'm a leading as a co-chairperson in Southeast Asia Regional Hub within the Challengers Committee at Nursing Now Challenge, London, UK. So today we'll see where is the cursor. We'll explore how to evolving practices in adult health and surgical nursing are not just improving outcome but also redefining our professional identity. So before starting that digestive disorders, I'm just going to give you overview of digestive disorders. In that, first we'll see what are the digestive disorders. So the GI system is a vital for nutrients, absorption, digestion, and waste elimination. Disorder can range from acute, maybe appendicitis, obstructions, and chronic. So nurses play a key role in assessment, intervention, and patient education. Why this topic matters? Because we are going to discuss and learning about digestive disorder. So first, we should know why this topic is important. So we'll see in clinical impact, GI disorders are common. Example, hernia affects more than 25% of men. And nursing challenges like pain management, nutritional support, and psychosocial care. So complications we'll see there, the untreated condition can lead to sepsis, perforation, and malnutrition. What are the learning objective? So dear students, at the end of this session, participants will able to understand common digestive disorders and pathophysiology, uh, like how to describe the underlying mechanism of hernia, fistula, IBD, and obstructions. Differentiate between Crohn's diseases. Implement nursing interventions. So we can see ostomy care technique, skin protection, prioritize pre and post operative care for hernia and appendicitis, manage angitubes and decompression for intestinal obstructions, recognize complication and emergencies. So, identify sign and strangulated hernia, perforated appendicitis, or fistula sepsis, respond to acute abdominal pain with appropriate intervention, provide centered care. So, basically, we educate patients on diet modification, just like low residue for IBD, addresses psychosocial challenges like a body image with ostomy, chronic disease coping, na? Apply critical thinking. So in that we can analyze case studies to prioritize nursing actions, collaborate on multidisciplinary care plans. All right. Next, first we'll see hernia, nursing assessment and management. So what is hernia? So if hernia, that means protrusion of an organ or tissue through a weakened area in the abdominal walls. That means hernia occurs when an organ or tissue protrudes through a weak spot in a surrounding muscle or connective tissue, like a fascia. Hernia are common and can occur in various parts of the body, but they are most frequently appear in the abdominal region. There is a many types of hernia, but we will today will see there are common types of hernia we will discuss here. So there is a common type of hernia in that epigastric hernia, umbilical hernia, inguinal hernia. Okay, we see always in the books and somewhere inguinal hernia, but I just want to recorrect. It is not a inguinal. Actually, it is an angular hernia, and angular hernia is the most common. Is a 70% of patient cases we are seeing. So likely it's a misspelling of inguinal hernia, and is the most common type of male, basically in the groin due to the testicular descent. Uh, Next one is umbilical hernia. It is near the navel, often in infants or adults with increased abdominal pressure. Next one is what? That is femoral hernia. So femoral hernia is nothing but it's a more common in women, especially those who are pregnant or obese. And other hernia are like incisional hernia, um, diaphragmatic hernia, stomach hernia, small intestine hernia. There are a lot of types. Okay, so if I say liver hernia, so liver hernia is a rare part of a liver that protrudes through a diaphragmatic or abdominal defect. There is a abdominal muscle hernia. There is a bulge through a weakened area of abdominal muscles. Next, see causes and risk factor. So first causes increase intra-abdominal pressure. So increase abdominal uh, pressure, that is due to chronic coughing. Basically, in COPD cases, we are seen that like on the patient who is having lifting, constipation, obesity, pregnancy, ascites. No, in that cases we see. Second one is weakness in the abdominal wall. So due to congenital defect and or aging, surgery, any trauma, malnutrition. Due to that, abdominal wall are going to weak. What are the risk factors? So risk factors basically age, muscle weakness, pregnancy, chronic constipation, previous abdominal surgery, na? So nursing focus, uh, if we will see, so we have to educate high risk patient on prevention. Example, proper lifting technique. What's the clinical manifestation? So first in reducible hernia. So reducible hernia is nothing but it is a bulge that can be pulsed back in or often painless. Next one is irreducible, or it will say incarcerated hernia. That is herniated tissue cannot be pushed back. It may cause discomfort, risk of obstructions if bowel is involved. Strangulated hernia, that is a medical emergency. And what are the symptoms? If a strangulated hernia, there is a severe pain, nausea, vomiting, fever, tachycardia, arrhythmia over the hernia, uh, non-reducible bulge that leads a sign of obstruction. That means absent bowel sound. So, as a nursing angle, we see strangulation requires immediate intervention because blood supply is cut off, and that leads to ischemia or necrosis. Next, see diagnostics test. What are the diagnostics tests in a hernia we can do? There is a physical examination. So physical examination cause bulges increase with cuffing, Valsalva, you know, ultrasound. Ultrasound why? For inguinal or femoral pediatric hernias, CT MRI for complex or post-surgical hernia, barium swallow or endoscopy for hiatal hernia. Na? Next is nursing management. So in hernia, first will pre-operative care. So pre-operative care, what we will do? Assess for sign of incarceration or strangulation and educate on avoiding heavy lifting. For hiatal hernia, small frequent meals we will have to uh, instruct, avoid lying down after meal, and elevate head of bed. है pain management, what we will do? Will provide ice packs, analgesic, analgesics in that NSAIDs, opioids, PRN. Activity we have to restrict, like we have to say to the patient 4 to 6 weeks. We need to avoid heavy lifting, wound care. One more thing, in activity restriction, encourage early ambulation because to prevent DVT. Next one is what? Wound care. Wound care to keep clean and dry, monitor for adherence. Next one is surgical treatment. In surgical treatment, first one is what? Herniography. Herniography means traditional open repair with suture. Second is hernioplasty. Hernioplasty, that means reinforcement to reduce recurrence. Laparoscopic repair. So laparoscopic repair minimally invasive, and it is a faster recovery. And Nissen fundoplication, that is for hiatal hernia. It wraps stomach around alias. What are the complications? So complications will face is strangulation. Strangulation, that is bowel necrosis. It leads to sepsis, ischemia. In these things, bowel necrosis, sepsis, hernia leads to perforation, and perforation leads to peritonitis. Second is recurrence. Recurrence, higher risk with poor wound healing or non-compliance, chronic pain, because nerve damage from mesh or sutures. What we'll see, we studied in causes, risk factor, clinical manifestation, diagnostics test, what are the nursing management, surgical treatment, complication. Now we'll see esophageal fistula. At the end of this session, I will give you time to ask your questions, or if you have any doubt. So what is esophageal fistula? Na? So esophageal fistula is nothing but it is an abnormal condition or connection, that means track between the esophagus and another structure such as a trachea, that is tracheoesophageal fistula or TEF, bronchi, mediastinum or skin. It can lead to life threatening complications like aspiration, pneumonia, sepsis, and malnutrition. What are types of fistula? So, first, tracheoesophageal fistula, TEF. It is the most common type, often congenital in newborn. Second one is what? Esophagopleural fistula. So, esophagopleural fistula, that is connection between esophagus and pleural space, that is pleural effusion or empyema. Next one, esophageal mediastinal fistula. So esophagomediastinal fistula, that is leads to mediastinitis, that is a life-threatening infection. Next one is esophagus esophagocutaneous fistula, that is rare and it form a tract from esophagus to skin. Like after post surgery, we'll see these cases. There is types of fistula. In that image you can see the types of fistula. Okay, next, causes and risk factor. So first is congenital. Congenital, uh, TEF in newborns, it is associated with esophageal atresia. Acquired, in acquired we see malignancy, that is esophageal or lung cancer. Trauma, by angitube, endotracheal tube erosion, infection, tuberculosis or fungal infections can lead, radiation therapy like esophageal damage, surgical complication, post-esopharectomy. These are causes and risk factor of what? Esophageal fistula. Next, we'll see clinical manifestation. So, there's a classical triad for TEF, that is coughing, choking with feeding infants, especially during swallowing, especially while liquid. Recurrent aspiration pneumonia, cyanosis, abdominal distension. In adult presentation, we'll see that is saliva, food particles in tracheal secretion, unexplained fever, mediastinitis, subcutaneous emphysema, that is crepitus on palpation, critical sign brassicough, that is pathogenomic for tracheal involvement, and other signs like fever, if infection present, subcutaneous emphysema, like air skin condition, weight loss, malnutrition due to poor intake, um, dysphagia, difficulty swelling. Na? Next is clinical manifestation. So diagnostics test. Diagnostics test. In diagnostics test, we will prepare patient for what? Contrast esophagogram. Contrast esophagogram is nothing but it is a water soluble first, which we avoid barium if perforation suspected. Bronchoscopy or endoscopy for monitor for respiratory distress post procedure. CT chest assess mediastinal involvement. Lab correlation like elevated white blood cells or C cells protein. है ना? So if white blood cells elevated and C reactive protein also elevated, that leads to infection or inflammation. Next is nursing priorities or and intervention. So nursing priorities and intervention. First, what immediate actions we need to require. So we need to NPO status, because NPO status is why risk for aspiration. HOB elevated, head of bed elevated, and the angle is 30 to 45 degree. Why? To reduce reflux. Double lumen NG tube, because proximal suction required if ordered, and ongoing care in respiratory, like in respiratory every 2 hour lung sound assessment, prepare for possible intubation. In nutrition, TPN initiation, collaborate with the dietitian, and strict I&O monitoring, IO monitoring, input output monitoring. Infection control, in that we need to provide antibiotic protocol, typically broad spectrum, and a meticulous oral care every 4 hours. Next one is surgical management. In surgical management, there are common procedures. First one, primary repair. Primary repair basically for small fistulas. For indication, what are the indications for primary repair? There is a small non-malignant fistula, like post-traumatic, iatrogenic, heavy surrounding is tissue. There is a no radiation damage or infection. So what technique required? So basically, direct suturing to the fistula tract and may involve reinforcement with the muscle flap. Example, intercostal muscle, है ना? Nurse in primary repair, what are the nursing consideration? If I say there is a patient that should have NPO for 5 to 7 days, because it allows healing. Contrast swallow study before restarting oral intake. Next one, esophageal stent. So esophageal stent, that is palliative or palliative for malignancy. So what are the indication for esophageal stent? So if malignant fistula, like esophageal cancer eroding into trachea, poor surgical candidate like advanced disease. What are the techniques for esophageal stent? So here we self-expanding or metal plastic stent placed via endoscopy to steal the fistula. And what is the nursing consideration? Monitor for stent migration, because sudden coughing or choking may obstruct airway. Soft liquid diet to prevent food impaction. GERD management. GERD. So it's because stent disrupt lower esophageal sphincter. Next one is divergent surgery. Divergent surgery, what? Divergent surgery nothing but is a spit fistula plus gastrostomy. That is divergent surgery. In that indication, if we'll say, what are the indications? So there is a complex or large fistula. Example, post radiation necrosis, failed primary repair. Hmm. What are the techniques? There is a cervical esophagostomy. It diverts saliva to neck skin. Gastrostomy tube bag for eternal feeding. Mm, Later reconstruction, example, colonic interposition. What are the nursing consideration while we are studying divergent surgery? So, stomach care, cleanliness with saline, protect peristomal skin, G tube management, huh? Plus 4 to 6 hourly, monitor for dislodgement. Next one is post-op focus, post-op nursing focus. So, in common procedure, what seen that primary repair, esophageal stent, divergent surgery. So in post-op nursing focus, what we need to do, what we need to focus, that is monitor anastomotic leaks. Why? Because it is a surgical emergency, and the early sign for monitor anastomotic leak is what? Tachycardia. It is the first sign. Fever, chest pain, neck pain, dyspnea. Dyspnea, that is due to mediastatics. It is just cause sepsis risk. What actions required while monitor anastomotic leak? So we have to instruct to patient NPO immediately, because leak confirm via CT or esophagogram. Broad spectrum IV antibiotics like piperacillin, tozobactam, chest tube if pleural involvement. Hmm. Next is what? Pain control. So in pain control, avoid NSAIDs. Because why NSAIDs we need to avoid? Because increased bleeding risk at repair site. That's why we have to avoid NSAID. And what we have to prefer? IV acetaminophen. It is a safe, minimal GI effect. Opioids, short term, monitor for ileus or respiratory dip depression. Next is what? Psychological support. Psychological support in what? Psychological support. There is some challenges in like in if we are providing psychological support, the nurses are facing some challenges when we instruct the patient to keep NPO status. So what happened? Patient will frustrate, fear of starvation, body image concerns like split fistula, G tube, anxiety about recurrence. So what nursing intervention required? We need to explain the healing timeline, like NPO for 5 days, then slow diet advance, This way we need to instruct to patient, involve a dietitian to provide TPN, G-tube, education, support groups like esophageal cancer survivors. So these are all surgical. This is all about surgical management. Next, we'll see complication and prevention. Complication. In complication, there is a deadly risks like ARDS. ARDS, that is acute respiratory distress syndrome. This is a chronic aspiration. Okay. And chronic aspiration of saliva, gastric content that leads to chemical pneumonitis and it can cause lung injury. So, what nursing action required? We need to immediate intubation if respiratory failures occur. Low tidal volume ventilation, ARDS net protocol you have to follow. Elevate head of bed 30 to 45 degrees. Why? To reduce aspiration risk. Next is sepsis. Sepsis due to mediastinal abscess rupture. Okay. So what are the causes? So the cause of sepsis is fistula allow bacteria oral GI flora to invade mediastinum. And due to that, what happened? It formed abscess. And abscess comes to rupture and patient will go in septic shock. So what nursing action required? So in that we have to blood culture, broad spectrum antibiotics like vancomycin, piperacillin, tazobactam, IV fluids like vasopressor if hypertension. CT chest to locate abscess, it may require drainage. Stricture formation. Structure formation, that is a long-term complication, long-term concern. So what are the causes? So it is a chronic inflammation and inflammation. So what happened? It fibrosis and due to fibrosis, narrowing of what? Esophagus. So what nursing action required? Monitor swallowing post repair, advocate for early dilatation, endoscopic balloon dilation. Next is prevention strategies. What prevention strategies required? So what? Proper NG tube placement verification. So proper NG tube place verification. Why? The question is why? Because mispositioned NG tube can erode esophageal wall. And if NG tube erode esophageal wall, what happens? It becomes fistula. So what best practice is? We have to confirm placement by what? Through pH testing, like gastric pH is more than 5, X-ray, gold standard before initial use, and secure tube wall well to prevent movement induced trauma. Next one is oral care protocols for ventilated patients. Why? Oral care protocols for ventilated patients. Why? Because ventilator associated oral bacteria, it causes aspiration pneumonia and fistula risk. So what we need to do, 2 hourly chlorohexidine swabs we need to use. Why we need to use? Because reduces bacterial load. Subglottic suctioning, it prevents secretion pooling and daily sedation vacation. Why? It reduces aspiration risk. Next one is early recognition of causatic ingestion. Why? Because acid alkalis it cause esophageal necrosis, and esophageal necrosis leads to perforation or fistula. So it is a emergency management, and what we need to do, remember, do not induce vomiting, because if patient going to induce vomiting, it worsen injury. We have to keep NPO and provide IV fluids to prevent further damage. Urgent endoscopy we can do within 12 to 24 hour to assess injury. So this is all about what? Esophageal fistula. Now we'll see next one, care of patient with ostomies. So care of patient with ostomies. So first we have to know what is ostomy and what are the types. So colostomy, basically three types, that is ileostomy, colostomy, urostomy. So colostomy is a large intestine colon, and the purpose is what? It diverts stool due to conditions like colorectal cancer, diverticulitis, or trauma. It's a ileostomy, that it is a location is in small intestine ileum, and is used for ulcerative colitis, Crohn's disease, or bowel obstruction. And urostomy, that diverts urine through an ileal conduit for bladder cancer, neurogenic bladder, or severe incontinence. So there's a one video I have to play. You just see. This is audible.
Yes, sir.
Okay.
सर इस वीडियो में कोई वॉइस तो नहीं है ना?
What, sir?
सर जो ये वीडियो चल रहा है इसमें कोई वॉइस तो नहीं थी ना?
वॉइस थी सर।
नहीं सर,
इट्स
वो
नॉट
वॉइस
ऑडियो।
नहीं आई है।
ओके। ओके, वीडियो मैं नेक्स्ट मैं शेयर कर दूंगा आपको सर। ये
जी सर।
बच्चों के साथ शेयर कर दीजिएगा।
जी जी जी।
ओके, ऑल राइट। Okay, previous in that video, I'll just share in your group as well as share to the sir. He will share with you. In that, there is a types of ostomy. Okay, so easily to understand. है ना? Where is the location? है ना? And what is the types? So now we'll see in ostomy care. First, we'll see pre-operative care. In pre-operative care, stomach making. So in pre-operative care, stomach making that is conducted by a WOC nurse. WOC nurse who is WOC nurse, wound ostomy and continence nurse who avoid uh, scars, bony prominence, patient education, to explain about procedure, stomach care, basics and address anxieties, bowel preparation. Bowel preparation, if ordered, like a clear liquid, laxatives is going. The post-operative care. In post-operative care, that is immediate and it for first 24 to 48 hours. So for first stoma assessment, is in stoma assessment what we will see like color should be pink, red, pale dark, that indicate what? Ischemia. Edema normal initially, that resolves in week. Bleeding small amount as expected. uh, Output monitoring. So output monitoring in that ileostomy, like greenish liquid output 500 to 1000 ml per day. Colostomy, it may take 2 to 4 days for first stool. And in urostomy, so drain clear or yellow urine continuously. Pain management will PCA or schedule analgesics. PCA like patient control analgesic. Early ambulation to prevent complication like DVT. Next, we'll see appendicitis from assessment to the post-op care. So, what is appendicitis? So, appendicitis is the inflow of the appendix. But if I say in other word, appendicitis is the acute inflammation of the vermiform appendix, a small finger-like pouch attached to the cecum. If untreated, it can lead to rupture, causing peritonitis, and it is a life-threatening infection of the peritoneal cavity. Here is an image. You can see it's a normal appendix. There is a abnormal. There is a inflammation of the appendix. What is the pathophysiology of appendix? So first we'll see obstruction. So obstruction because the appendix become blocked by what? Fecalis. Fecalis, that means hardened stool, lymphoid hyperplasia, tumors, or parasites. So due to that, increased pressure. So increased pressure, mucus and fluid buildup increase intraluminal pressure, impairing blood flow. And that leads to what? Ischemia and necrosis. So it reduces blood supply, leads to tissue death, bacterial invasion, and inflammation. Rupture risk. Rupture risk. So without intervention, the appendix may perforate, releasing bacteria into the abdomen. And is the final. What is the clinical manifestation of appendicitis? So it's a classical triad. So classical triad, there is a periumbilical pain. Periumbilical pain is initially vague. That is, it migrates to right lower quadrant, and that is known as McBurney point. Second is anorexia. Anorexia, that is loss of appetite, nausea and vomiting because after pain onset. Other signs what? Rebound tenderness. Rebound tenderness, that means pain upon release during palpation. Guarding, involuntary muscle rigidity. There is a Rossing sign. Rossing sign, that is in RL, right rural quadrant pain upon palpation on left lower quadrant. Psoas sign, that is pain on right hip extension. Obturator sign, that is pain on internal rotation of the hip. Low grade fever, higher fever suggests rupture. So this is the science, and it's a very important science to diagnose appendicitis. Tachycardia, tachypnea. There is also assessment trick, that is hop test, heel of test. That is, in what happened, we need to say patient to stand on hill. It's a clinical maneuver we use to assess for peritoneal irritation. In that, what happened? We need to say to patient to jump on the feet. And what happened if patient jump on the feet? The pain occur on right lower quadrant, and it leads to peritoneal irritation, and which may suggest that is patient is may be having appendicitis. Or nursing assessment and diagnostics. So nursing assessment and in diagnostics, what we'll do first, history and physical examination. So ask about pain onset, migration, and aggravating relieving factors. Assess for sign of peritonitis, that is rigid abdomen, distension, absent vowel sound. In diagnostics test, what we will do, we have to do CBC, because if CBC, what CBC, if increased WBC, white blood cells, that is leukocytosis, and more than 10,000 per mmq. CRP and ESR, that is if elevated, that means it indicates inflammation. Ultrasound and CT scan, because it confirms appendicitis. Check for abscess or perforation. Urine analysis, rule out UTI or kidney stone. Next one is nursing intervention and management. So in nursing and intervention management, first we'll see what? Preoperative care. Preoperative care if surgery is planned or appendectomy. So NPO status, that means what? Risk of aspiration during surgery. IB fluids, that is correct dehydration, maintain electrolyte balance, pain management, avoid opioids that mask symptoms before diagnostic, use acetaminophen if ordered, and in antibiotics, if inspection suspect, so we have to suppose to give what? Metronidazole and ceftriaxone. Avoid heat, laxatives, enemas. It can increase rupture risk. Post-operative care. Post-operative care, that is after appendectomy, after the surgery. So first, what we'll do? Monitor for complication. In complication, infection. Infection cause of fever, purulent drainage, abscess formation, with persistent pain, high white blood cells, paralytic ileus, absent bowel sound distension, peritonitis, rigid abdomen, septic shock. In pain management, we administer analgesics. Sorry, by in that PPT is not typed. We administer what? IB analgesic like morphine, ibuprofen, encourage splinting during movement. Why? To reduce discomfort. Early ambulation to prevent atelectasis, DVT, and ileus. Wound care. Wound care to prevent, to keep incision clean, dry. Monitor for redness, swelling, any discharge will come. If laparoscopic, that is a small incision, it heal faster. Diet advancement, start with clear liquids in advance to regular diet as tolerated. Avoid heavy greasy food initially. Complications, perforation and peritonitis, medical emergency. It signs sudden relief of pain, rupture, it followed by worsening pain, fever, tachycardia, hypotension, and what? Treatment, emergency surgery or broad spectrum antibiotics. SS formation, managed with percutaneous drainage, IV antibiotics. Sepsis, if systematic infection that requires aggressive IV fluid, vasosuppressors, ICU care. So this is about what? Care of, sorry, appendicitis. Now we'll see intestinal obstruction. So intestinal obstruction, it occurs when the normal flow of intestinal content blocked, leading to distension, fluid electrolyte imbalance, and potential ischemia, perforation. What are the types? See, first one, mechanical obstruction. So mechanical obstruction, that is what? That is a physical blockage. And 90% of cases um, are facing mechanical obstruction. And what are the causes? That most common: hernia, tumor, strictures, volvulus, uh, any obstructions like interception, that is a medical emergency, and it form of bowel obstruction, where an one segment of intestine folds inside to another. Fecal infection. Second one is functional obstruction. So functional obstruction, in other term, we will say paralytic ileus, and there is a lack of peristalsis. Peristalsis, what is peristalsis? Is a what? It is an involuntary muscle movement, basically that moves food through your GI tract. So what causes like surgery, electrolyte imbalance, hypokalemia, we can say, infections, we can say peritonitis, opioids, spinal injury. We can see this in image. You can see there's a bowel obstruction, the normal flow through intestines. So what is the key differences in mechanical and functional? So mechanical is hyperactive vowel sound early, and in functional we can say paralytic, that is a silent abdomen. So in early symptom, if we'll say mechanical obstruction, they will say hyperactive vowel sounds become, but after a functional obstruction, the vowel sound will become silent. Next, we'll see pathophysiology. So pathophysiology, first what happened? Obstruction is stasis. So it's stasis that why? Gas, fluid, and secretions accumulate proximal to the blockage, which leads to bacterial growth and distension, and it increase pressure, compromises blood flow, ischemia, necrosis, hmm, that leads to ischemia, necrosis, and then perforation risk. So perforation risk, if untreated, or bowel may be rupture, that leads to sepsis, peritonitis, and maybe death. So, once again, I just explain you in pathophysiology, obstruction, that cause of fluid or gas of secretion that accumulate in proximal to the blockage area. And what happened? Bacterial overgrowth and distension that increase uh, pressure, compromises blood flow, and through that ischemia, necrosis, that leads to perforation risk, and if untreated, or bowel wall, it may rupture, so that leads to sepsis, peritonitis, or death. Next, we'll see clinical manifestation. So in clinical manifestation, there is a classical triad. So classical triad, that is colicky abdominal pain, that is cramping intermittent, distension, visible loops on inspection, vomiting, that is early gastric content, and in late early phase there is a gastric content, but in late phase, that is bilious, uh, filulent, absolute constipation, there is a no flatus or stool. What assessment pills? So we can do auscultation, high pitched tinkles, like early silent abdominal, if late. Peritoneal signs, rigidity or rebound tenderness, surgical emergency. Auscultation, peritoneal signs. Diagnostic workshop, like diagnostic evaluation. So priority test, what will do? AXR, step leader, that is air fluid level mechanical, or diffuse gaseous. CT abdomens to identify transition point, strangulation signs, pneumatosis, labs, elevated lactate, leukocytosis. Nursing role we can perform for, position for upright abdominal during X-ray. Monitor for contrast aspiration, uh, risk if CT with oral contrast. Next, we'll see nursing priorities and intervention. So, nursing priorities and intervention, there is a immediate actions. So, in immediate actions, what we supposed to do? If obstruction is there, what we supposed to do? So, NPO and NG tube. Why? Low intermittent suction. Because why NPO NG tube we are consider here? Because risk for aspiration. We are going to IB fluid. In IB fluid, what we are supposed to give? Isotonic solution. There is a 0 to 9% NS or LR to correct dehydration or maintain blood pressure. Pain control to avoid opioids if diagnosis uncertain. May mask peritonitis. Monitoring, what we have to monitor is strict IOS, input and output chart. You will risk for dehydration or electrolyte imbalance. Abdominal girth for hourly, marker for of progression. Next is complication and prevention. So, complication and prevention, there is a greatly tried of complication is what? Perforation. Perforation, that is sudden relief or rupture sign. There's a bowel rupture. So prolonged obstruction, what happened? It increased intraluminal pressure, and increased intraluminal pressure leads to ischemia, and it can cause necrosis and rupture. What are the clinical signs? Like sudden relief of pain, rigid, hypotension. So, nursing action, what you supposed to do if perforation found? So we need what? We need to monitor, prepare for surgery. Call surgeon immediately. Prepare for surgery. NPO, ask patient for NPO, IBSS, provide antibiotics, monitor for septic shock, lactate, BP, urine output. Hmm? Second is sepsis. So sepsis, that is tachycardia, fever, hypertension, but it is a bacterial translocation. So if a tissue, dead bowel tissue release bacteria into bloodstream. That means dead bowel tissue, what release? Bacteria into blood stream. So it's a systematic inflammation and it can cause septic shock. So what nursing action required here? Start broad spectrum IV antibiotics, in that what? Piperacillin, tazobactam, fluid restrictions 1 to per liter, NS bolus, vasopressors if needed, norepinephrine. Okay. Third is short bowel syndrome, if extensive restriction. So short bowel syndrome is after massive resection. So surgical removal of more than 50% of small intestine, malabsorption, diarrhea, malnutrition is common. So what are the clinical signs like chronic diarrhea, weight loss? I already told you. What nursing actions we need to take? So TPN, total parental nutrition, until bowel adopts. Small frequently meals like low fat, high carb, lifelong vitamin supplements we need to provide. Prevention strategies. The first one is early ambulation post-op to reduce adhesion. So early ambulation post-op, why? Because movement prevents fibrous brand adhesion from forming between intestine, and adhesions are the number one cause of what? SPO, 60 to 75% of cases. What nursing roles, if required? If early ambulation post-op reduces, what nursing action required? So encourage walking within 8 to 12 hour post-op, incentive spirometer use to prevent atelectasis and promote motility. Bowel, second one is what? Bowel regimen for opioid user. Why? Opioid slow peristalsis, and if peristalsis slow, it leads to constipation, and constipation cause fecal impaction, and because of fecal impaction there is obstruction. So what nursing intervention required? Stool softener or stimulants like docusate or and Sina. Hydration 1.5 to 2 liter per day unless contraindicated. High fiber diet if no obstructions. Monitor bowel movement. Document frequently and consistency. And other key preventive measures. What we will do? Like risk factor prevention, strategy hernia, avoid heavy lifting, surgical repair if symptomatic, diverticulitis, high fever diet, avoid nut seeds if history of what? Diverticulitis. So this is about what? Intestinal obstruction. So today we will see in the digestive disorder, hernia, esophageal fistula, care of patient with ostomies, appendicitis, and intestinal obstruction. So in this topic, if you have any doubt, any query, you are open to ask. Hello, sir. Are you there?
Yes, sir. Thank you, sir.
Students having any question?
Anyone want to ask you questions? Chat box is yours, participants. कोई भी कोई क्वेश्चन पूछना चाहे पूछ सकता है। चैट बॉक्स खुला हुआ है आप लोग के लिए। आई थिंक सर।
I think every students are
जी जी जी, उनके पास अभी कोई क्वेश्चन नहीं है।
understand very well.
जी सर। बाकी सेशन वाज वंडरफुल सर।
Okay.
जो भी टॉपिक
Actually,
डिस्कशन हो।
I didn't get more time. In digestive disorder, there is a more topics like Crohn's disease and colitis. I didn't included due to shortage of time. But next time I will try to complete all these topics also.
यस सर, नो इशू सर। नेक्स्ट टाइम वी विल, जब भी नेक्स्ट सेमिनार होगा एमएसएन सेकंड का, वी विल कांटेक्ट यू सर इन फ्यूचर। आप पूछा मैम, एक मिनट। यस मैम।
Good afternoon, sir. Good afternoon,
Yes,
everyone.
good afternoon.
As we come to the close of the sixth day of webinar series on refining nursing practice with a focus on adult health and surgical care, it is my privilege and honor to deliver the vote of thanks. First and foremost, I would like to express our heartfelt gratitude to our esteemed speaker, Mr. Rahul K. Sarma, Principal, RIMS, Pratapgarh, UP. Sir, your session today on digestive system insightful and enriching. You presented complex concept with such clarity, making it easier for all of us to grasp and connect theory with clinical practice. Your knowledge and expression have certainly added immense value of our learning. A special thank you to all our participants for your active engagement. I would also like to acknowledge the effort of our organizing team for their dedication behind the scenes to ensure a smooth and productive session. Let us carry forward the knowledge gained today and continue to refine our nursing practice with great confidence and competence. Tomorrow's topic is oncology nursing care. Once again, thank you to all, and we look forward to welcoming you tomorrow for another enriching session. Have a nice day. Thank you.
Okay. So actually, I didn't give an conclusion. I just want to conclude.
यस सर।
So this brings us to the conclusion of today's comprehensive discussion on critical adult health and surgical nursing topic. I trust that the knowledge and perspectives shared have enriched your understanding and will contribute meaningfully to your professional practice. As nursing professionals, it is incumbent upon us to continually advance our expertise, embrace evidence-based practices, and uphold the highest standards of compassion and professionalism in patient care. I extend my sincere gratitude to the organizing committee for providing this STEM platform to all participants to their engaged attention and thoughtful participation. I was absolute honored to be part of the national webinar series on refining nursing practices focus on adult health and surgical care, hosted by Samarpan Institute of Nursing and Paramedical Sciences. Thank you for the opportunity to share insight alongside such esteemed professional and engaged with a passionate audience of nursing practitioners and students. I deeply appreciate the meticulous organization and the platform you have created. At the end of and with inspiration, as a Florence Nightingale said, Nursing is an art, and if it is to be made an art, it required as exclusive a devotion as any painter's or sculptor's work. Go make your masterpiece. Wishing Samarpan Institute continued success in your impactful initiative. Looking forward to future collaborations. Thank you so much. Thank you so much, sir. Thank you so much, ma'am.
Thank you, sir. Thank you very much, sir. Thank you, all participants. We will meet you tomorrow. Next session.